Hi, welcome everybody. My name is Brady Granger and I co-chair the CANS Special Interest Group for Clinical Nurse Scientists in the practice setting with Mary Fran Tracy. And today we are continuing a series that was started in 2020 about the roles of nurse scientists in clinical settings and how nurse scientists work in practice settings to advance nursing science. So today we have a guest speaker that I would like to introduce, who is a longtime friend and colleague, DaiWai Olson. He is a professor at UT Southwestern, and I'll just give you a second of background, although it's hard to fit DaiWai's background in a second. But he began his career in the 80s in Iowa and practiced for over 30 years as a staff nurse in the neuro ICU setting. He obtained his PhD at UNC in Chapel Hill, North Carolina, and was an assistant professor here at Duke, which is where I came to know DaiWai and have the chance to work closely with him. He has been at UT Southwestern now since 2012, where he has achieved the status of the first full professor awarded at that university, and continues his work in the neuro department, helping to achieve advances in nursing science with the staff there. In the process of his work, he has been incredibly prolific and made huge contributions to the profession. He has published over 250 papers helping nurses understand how their work and care contributes to patient outcomes. He has become editor-in-chief for the Journal of Neuroscience Nursing. He's co-chair of the International Neurocritical Care Research Network. And he has worked and presented in 39 states in the US, 10 countries, and 5 different continents. So I am honored to have him present to us today on a topic that will help us, I think, as a special interest group to build and use registries in our practice of advancing nursing science. So welcome, DaiWai, and thank you so much for joining us today.
Thank you, Brady. Thanks for the introduction. This is a topic that's pretty near and dear to my heart, and I'm excited. So let's jump on in. This is about building and running a nurse-led registry. We've all heard about registries. Typically, most commonly, they're run by someone other than a nurse, and I think that's not a good idea. These are my disclosures. Neuroptics and Department of Defense are probably relevant to the content I'm going to talk about today, but I will make every effort to be impartial, and I think you'll see I do that pretty well. The focus of my work for the past 25 years has been that I think nursing is important. I think nursing makes a difference. I think nurses make a difference. And so far, nobody has stood up to me and told me I'm wrong. However, what do we really mean by that? And I warn everybody right off the bat, I'm going to get into statistics right from the get-go. And I know some of you are having PTSD right now, but we're going to get through this together. The first thing that comes to mind when we talk about stats is the famous regression formula. And I know I've triggered things with some of you. This is read pretty simply. This formula of funky letters is the outcome is predicted by where we started plus the influence of a bunch of variables plus error. I'm going to break that down a little bit differently. This is the same formula, and I'm going to color code it for us. The outcome is Y, the letter Y. It's predicted by, this pink color is the equal sign. Where we started, that's that beta knot. All those B1, X1s, the beta 1, X1, beta 2, X2, that's variables. The plus signs are plus, and the little weird looking E is error. So we can map this, that the outcome is predicted by where we started plus the influence of a bunch of variables plus error. I'm going to give an example, and I'm going to use a neuro example because I'm a neuro nerd. We're going to think that the 90-day modified Rankin score is predicted by how well the patient was before they had a stroke plus their NIH score, plus their age, plus whether or not they got alteplase, plus sex, plus a bunch of other stuff that we didn't happen to measure, and then error. And you can see on the bottom, that's just discharge, modified Rankin is baseline. How were they before their stroke, plus the variables, plus error. Now, I'm going to focus in for a second on the other stuff, because a lot of the times we talk about all the other stuff, the random variables, and we act like that can be controlled for by randomization. My argument is the other stuff is me. I'm the other stuff. I'm, the bedside nurses. We're the other stuff that didn't get measured. And the question is, do we make a difference? That takes me back to that initial question. Did we make a difference? And you can measure a lot of these variables, and this is the same formula laid out a little bit different. Let's take that stroke, and then we've got a bunch of variables, and our intervention is whether or not the patient got alteplase, TPA, and typically we get these little r squareds that explain a proportion of the variance, and if you add all of them together, you can see that in my hypothetical example, the intervention plus the known variables, age, NIHSS, sex, can tell us about 70% of the proportion of variance and why a patient has a good outcome or a bad outcome. And then nursing is just lumped in with confounders. Well, it's probably lumped in with confounders because we don't really know how to measure it. Now, there's other stuff that's lumped in with confounders too. We can measure an awful lot of things. We don't measure everything that's possible because some of the things we think are important and some of the things we think are not important. I think nursing care is important, so I think we should measure it. And when we theorize what we do and don't measure, we have to start thinking about how did all of this come about? See, there's that theory word. First, I hit you with statistics, then I throw out the theory word. A lot of you are really kind of getting those heebie-jeebies. Well, statistics and theory are hand in hand. Originally, we had a belief, not a theory, a belief. We believed that the gods caused us to be sick. And then they developed theory. They had a theory that there were 4 things: blood, yellow bile, black bile, phlegm. And those 4 things together explained how we got sick, and they explained disease. Well, they started testing these theories. And by testing these theories, they realized, yeah, this whole 4 humors theory, that didn't work out. There has to be a different cause for disease. But we had already moved beyond rejecting that disease was simply by gods. So medicine started out as very theory-based, and oddly enough, in the past 100 years or so, it's become a little bit less theory-based. It's not really as theory-based as it was, whereas nursing has become more theory-based, especially after World War II. Now, in nursing school, in my undergrad, when I had to do my theory class, I hated theory. And then I became a nurse theorist, and now I like theory. Odd how that happens. Here's my theory. This is called the cue response theory, and this applies specifically to patients with brain injury. We're not going to go over this real in depth, but you'll see how it applies to why I now have a registry. Imagine that a patient has an event. They get hit in the head with a baseball bat. That causes a brain injury. The brain injury results in impaired brain function. Then nurses, we have things we have to do. These are called interventions. And we watch the patient, we observe, we look at them, we check their vitals. Those become cues. And we interpret those cues to decide when things should happen. And deciding when something should happen becomes as important as deciding what should happen. And I think this is part of the essence of what nurses do at the bedside. This is that critical thinking. And I'm going to give you 2 quick examples. The first one is a bad outcome. So ICP is intracranial pressure. We put a tube in someone's skull and we measure the pressure inside their brain. Big numbers are bad. An ICP of 32 is seen in this patient, and a brand new nurse comes into the room and says, oh my gosh, they had a poo, I better clean it up. So she lowers their head of bed, she cleans the patient, she rolls them from left to right, puts on new sheets, looks up, the ICP is now gone from 32 to 56. The patient herniates and they die. That's a bad outcome. And we can directly link that something the nurse did, this one action the nurse did, led to a bad outcome. The reason that's important, if nursing care can cause a bad outcome, then a nurse and nursing care can also cause a good outcome. So by proving the negative or by pushing the negative, I think I can demonstrate that there's a reasonable assumption that nursing can lead to good outcomes. We'll take the same patient, different nurse, ICP is 32. This nurse walks in, says, oh my gosh, look at that, the patient had a poo. But more importantly, one of the cues they're giving me is their ICP is 32. That's intracranial hypertension. I'm going to raise their head of the bed instead of lower it. I'm going to contact my NP. The NP is going to order some mannitol, and I'm going to wait until the ICP is back down to 12. Then I'm going to clean the patient, and my patient is going to move on a trajectory towards recovery. The thing is, it's kind of hard to measure that. So that has led me to look at what kind of cues in neuro can I assess that help me determine when something should happen. And not only me, but other nurses, because if I can measure this, maybe I can figure out the R squared, the proportion of variance in outcome that can be explained by good nursing. This is where I became interested in pupillometry. I'm interested in pupillometry because of the above. You should be interested in pupillometry because, as I'm going to show you, pupillometry is nothing more than objective data. And if I give you bad data, if I tell you bad data about the pupils, it's very hard for you as an advanced practice provider to make a good decision. Brief review of neuroanatomy. Yeah, I know, statistics, then theory, now neuroanatomy. What a sucky lecture, right? So this is a 30,000-foot view, the easy thing. And we're going to look at afferent, intraneuron, and efferent. Essentially what happens is light hits the eye. That signal travels along the second cranial nerve to something called the Edinger-Westphal nucleus, where the EW sends a signal back to both eyes and causes those pupils to constrict. That's the basic pupillary light reflex. And that's going to be important because we're going to talk about this. All of you have taken a flashlight and looked at a PLR. Here's my hypothetic. You are the APP taking care of a patient, and you get a call at 5 minutes after 2 o'clock in the morning. Miss Brown isn't doing well. And this nurse starts to tell you the assessment. And in part of that assessment, the nurse says, oh yeah, the pupils are equal, round, brisk at 3 millimeters. Then you double check. You talk to the resident who happens to be on. The resident says, yeah, they're Pearl, because he's cool. So, you know, he'll just use the acronyms. If I tell you that the patient's pupils are equal, round, and reactive at 3 millimeters, in 2018, I would agree with you if you said you have an understanding of whether or not the patient has an intact pupillary light reflex, and in 2019, you don't know squat about how well the patient's pupils are working. And that's the cool part that drove me to this registry. So the first thing I'm going to talk about is a study that we did, and this data is not in my registry. This is the data that made me think, damn, we need a registry. And I didn't have IRB approval to keep this in, but what we did is we looked at 2,329 paired observations. In other words, just about 5,000 observations of two different eyes. And we wanted to know, if I look at this patient's pupils and you look at this patient's pupils, will we get the same assessment? Now, right now, all of you are going, you know, I did this for years and years and years, and I remember looking at this patient and going, well, I think they're 3 millimeters. I'm going to ask somebody else. And that person agreed with you if they liked you, and they disagreed with you if they didn't. And then you go, are they reactive? I'm not sure. Are they reactive? And you double checking and squinting your eyes like that's going to help you, right? And it turns out, here's the data, and we're not going to go over this whole spreadsheet, but it's on there. We agree a lot. We agree a lot. There's a problem to that. So on the size of the pupil, we agree about 80%. That's not too bad. 8 out of 10 times we disagree on how big or small the pupil is. On whether or not the pupil's round, isn't that weird? We can't even agree on whether they're round, except 95% of the time. But reactivity, 80% of the time we agree, which means 1 out of 5 times we disagree on whether or not it's reactive. But agreement is not the correct statistic. Agreement is not the correct statistic because if I randomly asked you and you didn't go into a patient's room, you don't even look at the patient's room, and you say, I bet that patient's pupils are 4 millimeters in diameter, they're round and they're brisk, you'd be right 95% of the time without even looking, because 95% of the time, that's how it is, right? So what we need instead is something called a kappa statistic, which is much more robust for looking at this because we're looking at rare events. And now when we did our kappa statistic, it turns out humans suck at judging pupils. That's because the pupillary light reflex is so fast. We got a kappa of 0.4, which is poor, on whether or not the pupil is reactive. And I will share with you, we did this with physicians, we did this with nurses, we did this with 2 nurses, 2 physicians, 1 nurse, 1 physician, APP, and we did every combination. And we couldn't get but about half the time on the patients with fixed pupils that they agreed. And we had at least 2 people judge a patient who had a prosthetic eye as having a reactive pupil. So humans aren't very good at this. That was the key. That was the key to this registry. As we were starting the registry, we wanted to make sure that what we were seeing was not a phenomenon specific to just, the neuro ICU and floor patients. So this is Lillian Umbro, and she did a study in PACU and found exactly the same thing, that humans are not very good at looking at pupils. And so we found this device called a pupilometer. And the movie that you're seeing off to the side is a pupilometer assessment. Basically, you target the pupil, and there is a high-speed camera that takes really fast images of the pupil, and it scores how fast your pupil gets big or small. Now, the really cool thing, too, is you can see on that. You could see the pupil getting small, and here Danielle is showing us the values. What you're looking at in the graph is variables you never heard of before pupillometry. There is a period of time between when the light goes on and when the pupil starts to react. It's about 1/10 of 1 second to 3/10 of 1 second. The human cannot judge that. Then there's the speed. There's how fast does it get small. We used to call this brisk and sluggish and stuff. And then there's how fast does it come back to normal? And is it different if it gets big or small from different baselines? And the answer is yes. And we said, well, if we're going to start looking at all these variables, we need to come up with a registry. So I started this registry, and this gentleman who you can see trying to win an ugly sweater Christmas contest by wearing an ugly suit said the first thing we better do is also in this registry, make sure that even though 2 humans get a different answer, do 2 devices get a different answer? So we did an inter-device reliability study, and it turns out that kappa is 0.97. And the 0.97, it was 100.1 or 1.0 for whether or not the pupil was fixed. So this is 0.97 on the NPI, which is an overall assessment. All right, so here's where we're at. Humans, we're not very good at judging pupillary light reflex, which really is no different than anything else we've done. We used to check temperature by putting our hands on a forehead, right? And we'd say fever, no fever, right? And kind of judge it. We used to judge their blood sugar. A lot of us have been around where we had the tape where you tipped in and you checked the color, right? And you figured out how much insulin they needed by the color of the paper. And then we became metered. We have a pulse oximeter that is more accurate than squeezing their pinky and looking at their lips. We have a thermometer that is more accurate than feeling their forehead. We have a pupillometer that is more accurate than looking at the pupil. And we started something called the END panic, establishing normative data for pupillometer assessments in neuro-ICU. We started the END panic registry with neuro-ICU because we thought that was our bread and butter. We have sites in Japan, California, Texas, Ohio, Pennsylvania, and Germany. This is entirely nurse-run and nurse-led. We have over 5,500 patients in this registry, 90 variables, and over 6 million assessments. We have a large registry. But the first step in this registry was, we're not going to write the methods every time we do a paper. I'll cut to the chase. We're on paper number 29 of this registry. We're not going to write the methods. So the very first thing we did was wrote a fairly extensive methods paper of how does data get from the patient into the registry. And this is our methods paper. And I encourage you, if you're going to do a registry, do a methods paper, because we cite this every time and it saves us like 20 paragraphs. We also have described methods for how we clean the data and how we manage the data. This is an ongoing registry. It's not a one-time only. In fact, I got another data dump just last week from Japan. So that next chunk of data needs to go into the registry. So I've got about another 200,000 observations to get in. And how do you do that? And you need a rigorous process, and this talks about that. We also wanted to set the baseline. We have, from the company, they have described what normal means. But no one's done that outside the company, and we wanted something unique and private and separate. So this is a paper that set the norms, right? So this is the distributions, reference ranges. That means if I check on a patient, a normal patient who's healthy, I'm going to get an NPI of about 4.2. And their pupil is going to be about 3.5 millimeters in size. Latency, how long it takes from that light to go on until their pupil starts to react, is about 0.3 of a second. The velocity, how many millimeters per second that pupil gets smaller, is 1.6, and their dilation velocity is 0.7, a little bit slower. So that's an important piece. Then we started really digging into the data, and this is the paper that has convinced all of us that 10 years from now, you will not use a flashlight. In fact, we're done with flashlights. There is no reason to be using a flashlight or a pin light. First off, you're not very accurate. We showed that with our first paper. We've shown that repeatedly with the registry. This was our other aha moment. I got called down to the intensive care unit by one of my residents who was really pissed off at me because he hated the pupillometer. And the pupillometer said that the patient had an abnormal pupil reflex, but he could see the pupil was really brisk, and that he was just upset. And at first I didn't really understand it. But then with the help of Ife Shiyambo, we did a fairly complicated analysis that was picked up by Nature Scientific Reports. And now it makes sense to me. Both of the cars that you see are going brisk. Both of these cars are brisk. They're really, really fast. One of these cars, and I think you can picture which one, is not functioning normally. So just being brisk doesn't mean everything's working okay. The best example we picked out of this is, imagine the patient with a pupil that's 8 millimeters round, big old pupil, and you shine a light in that eye, and that pupil goes from 8 millimeters really quickly down to 6.5 millimeters. Well, that's brisk. But if that pupil only goes down to 6.5 millimeters, there's something wrong. That's not normal. And then what about the dilation? What if it doesn't dilate again? Or what if it dilates super fast or super slow? So we're digging more into this, and we've got some exciting data to share probably in about 6 months. So I'm super excited. There's even more coming out. This is why if the nurse calls you at 3 in the morning and says their pupil is brisk, you still don't know if it's normal. You don't know if your patient's okay. And a slow pupil might not be abnormal. That's the other cool part. Slow pupils are not necessarily abnormal. Because intracranial pressure is so part and parcel to the intensive care unit, and because of my other work with nursing, we did a study where we replicated work by Dr. Molly McNett out of Ohio. She found an association, and Molly's also a nurse. She found an association between intracranial pressure and pupillometry. So we checked it. You know, we're all taught to do these replication studies, but then you never really see them. We did it. We did a replication study. We managed to publish in Critical Care Explorations, which is a strong journal. Super happy about that. Found exactly the same thing as Molly. So it's becoming more robust. The picture you see in the upper corner there is Salah Aoun. He's a neurosurgeon, and he hated me. And he hated pupillometry, hated us. And I started this registry, and oh, I got so much flack from him. And he wanted to prove that this thing was a piece of crap. So I said, all right, let's design the study. And we did. We looked at his subarachnoid hemorrhage patients, and it turns out the pupillometer, the findings on the neuropupillary index are strongly correlated with the delayed cerebral ischemia, which is a precursor to neuro changes. In fact, we see them up to 8 hours. You see changes in the pupil up to 8 hours before you see changes in the neuro exam. So he has gone from hating pupillometry to now he's doing concussion research and TBI research. This is Stephanie Ortega-Perez from Colombia, South America. And she came up and did a study with us on pupillary light reflex as a predictor of outcomes from subarachnoid hemorrhage. This is modified Rankin score. Robust patients whose pupillometry values go up and down and up and down and up and down. These are the unstable patients. Even if their GCS is stable, even if everything else is stable, patients who have high variability in their pupil scores have a worse outcome, which is kind of a neat little finding. This was a correlation between shift, how much shift in the pupil there is off of midline, and that's in stroke patients. This was eye color. This was a gentleman named Sam Alabaidi. We were challenged that pupillometry would be different based on the color of your eyes. And so we looked at that, and it turns out, nope, no difference based on eye color. You're just fine. So we don't have to look at eye color. Again, with Salah, we looked at in traumatic brain injury patients. If your pupillometer is normal, you're solid, but you can see an NPI change in these patients up to 12 hours before symptoms. And unfortunately, we found this out the hard way, where we had a patient who had pupillometer changes, and we told the resident, who didn't do anything. 4 hours later, there were worse changes. He didn't do anything, and 4 hours later, unfortunately, the patient passed. So we learned a lot. We reported that case study. Another study with Dr. Wera Kuhn. Most of you have heard of Horner syndrome, and pupillary light reflex is part of Horner syndrome. And after endarterectomy, where they're stretching that carotid plexus, you can mess up the sympathetic parasympathetic, and that's where you're seeing pupillometry changes there. So it's nice to see that the physiology works. This was for traumatic brain injury. Patients who had normal NPIs did not require surgery. This was 100% sensitive and specific, rocking the world of neurosurgery on this because it's got a higher predictability than the Glasgow Coma score. So in other words, now you've got an objective measure that you can put in the hands of a paramedic or someone on the field, which is why my DoD conflict. So you can put in the hands of a medic looking at soldiers. You don't want a soldier in the middle of the field do pronator drift and stuff like that. You can look at their pupils and help triage. So this is pretty cool stuff. These are a couple of other papers that we've got going. And what I'm trying to share with you is that the development of this registry, you can see a lot of these questions. These are nursing questions, right? How does what I do, how does my assessment ultimately influence care? And how does the accuracy of my assessment, I'm better, I'm more on target, I'm more accurate. How can that make a difference in the patient outcome? And now we're seeing like up to 12 hours difference. So huge, huge. These are a couple of papers. Both of these have been accepted now, and they should be coming out in early January. As I'm speaking now, it's still December. So the question has been sort of answered for us. It's no longer a question of will we continue to use flashlights. It's no longer a question of if we'll use pupillometer. We've seen that. Now we have a whole new set of questions. How often should we check? When should we call? What kind of biomarkers? What kind of patients? And all of these are questions that, because we took the time to build this registry from the get-go, we can be asking these questions. And I think that's my 30 minutes. And I will be logging on. I look forward to your questions. This is my email. Please feel free to send me some comments. Thank you very much for listening.
Thanks, DaiWai. This is Brady again. I appreciate your talk and the recording today, and we look forward to having a live discussion in January, February with the CANS group. Thanks everybody for joining.